Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by my magical, duplicating co-host, Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon, and he plays one on TV.
I do.
If you are listening to this, you have no idea what I'm talking about. Dr. Martin brought his bobblehead back in for a little cameo. Love it. It's our favorite co-star.
The bobblehead has an ego. You got to fill it a little bit, you know.
He needs his screen time.
He needs a little screen time.
It's been a while.
Yeah, it's been a while.
Yeah, if you are listening to this podcast and you'd like to watch the antics that are taking place now and every time, you can find those on YouTube at Jason Martin MD. You can also find all of our social media handles here. If you'd like to leave us a text message or a voicemail, you can leave that at 303-630-9038. Dr. Martin, this is part 2.
Part 2.5.
Yes, of our Everything You Need to Know About Breast Augmentation. So if you have not listened to the first part and you want to know who's a candidate for this surgery, the statistics, what you need to know about pre-op, your consultation.
Basically all the Amy stuff.
The first stuff.
Yeah.
Yeah. So in this episode, we are going to talk more about
the Dr. Martin stuff.
The surgery itself and also risks and complications. Like, this is the follow-up. So part 1 was everything up until surgery, and now we're talking about surgery and beyond.
Good.
So we're going to get right into it.
Let's go.
Surgery and beyond. All right. So Dr. Martin, the big question here that we did not address in our last episode, silicone or saline?
Right.
Yeah. So I have this great little chart here that kind of gives the back and forth. So the key thing that I think is not well enough known is that both of these implants have a silicone shell filled with either cross-linked silicone gel or
saline,
which is sterile water. Yes. So
you're still exposed to silicone.
You are. Mm-hmm. Yeah. Big difference.
It's a crazy thought.
Yes. The shell is the same.
Yeah.
FDA approved for 22 years and older with silicone. FDA approved for 18 years and older with saline. Start getting into the big differences here. Silicone definitely feels more like breast tissue. Saline definitely does not feel like breast tissue. They're both highly durable. Silicone is going to be ideal for most sizes and situations. I would say the only benefit that saline has over silicone is specific types of placement, which we'll talk about next. And if you're wanting to go with a very large size, because saline can essentially be overfilled, whereas silicone is the size it is.
Right. So I think the maximum you can get is around 800.
Yep. Around 800 with silicone.
Yeah. There's a few that make it a little bit bigger, but to say 800 for, for comparison's sake, and saline, you can overfill. Secondly, the incision you put an 800cc implant through has to be a certain amount of length just to fit it in there.
It's a big implant.
Where the saline implants, you can make the incision really small, stuff it in there, and then expand it out. So it's like you can roll it up like a cigar, like literally put it in there. So that's the benefit of the saline, but it's inferior the way it feels, the way it looks. And the only reason I think you would get a saline these days, in most cases, is number one, you're between 18 and 22, and the person is actually doing what they're supposed to do, or money, because the saline implants are less expensive.
Yeah.
So
by like a third. I mean, they're a lot less expensive.
Is it that much difference?
Yeah.
Okay.
They are far less expensive.
Right. And I, if that's where you are in your life and you can only get a breast augmentation with a saline implant, I think you need to rethink this, because the silicone is so much more superior than a saline implant.
Absolutely. I mean, really, to say that, silicone feels pretty similar to breast tissue is real, and to say saline does not, also true.
Yeah.
Like a saline implant just has a very distinctive feel about it, which is fine. But those are things that you really should be aware of. If money is the deciding factor for you, like Dr. Martin said, like maybe really rethink that.
Yeah.
Because it is a far different
And when salines
feel.
fail, you know it, because they pop and then it deflates.
Yeah, there's the advantages and disadvantages of both. And that is definitely one of them. With a rupture, you don't have a leak. It's not like you might not know that your implant has ruptured. If your implant has ruptured and it's saline,
Yeah.
The waterbed.
Yeah, or it's like gone.
We every now and then we get a phone call like that. I think I've ruptured my implant. Well, how do you know? It's deflated.
It's flat.
So, you probably did.
Yep.
So there's two options for placement of implants. Nils, you know these options. Above and below the muscle, right? What's the muscle, Nils? What's the muscle we always talk about?
Pectoral?
Yeah, pectoralis major. Yeah, major muscle. And there's also a minor,
It's
Nils.
very high.
But that's under up here and underneath the major muscle. So above the muscle or below the muscle. It's really like, what's your flavor?
I feel like this should be like dueling it out.
Right.
Like, it's like the two camps, above and below the muscle.
Exactly. Above the muscle is referred to as subglandular. Underneath the gland of the breast tissue, like where the ducts of the breast tissue are, where your nipple and areola are. And below the muscle is called submuscular. So, Amy, what are the benefits of subglandular?
You can get a very natural looking outcome because the implant is kind of not constrained by anything. So it really looks very natural in the breast, less postoperative pain because you have not violated that muscle wall, and you avoid animation deformities. So because the implant is not being pressed upon by the muscle, that same reason, like I said, you get a very natural looking appearance. You also will not get any changes to that implant when you flex your pec.
Okay. And those those deformities with movement are called kinetic deformities or animation deformities, and specifically what you get with breast augmentation is a window shading, like literally the words window and shading deformity. So you can look that up.
Pull it up.
Yeah.
Pull up a shade.
So what are the disadvantages of subglandular, Amy?
You have an increased risk of capsular contracture. You're putting a lot more pressure directly on that breast tissue. So you have an increased risk of implant show, wrinkling.
Which is the major issue, and rippling.
Yep.
So
and wrinkling too of the skin even.
The skin, yeah. So any kind of contour, and look up rippling of an implant. So, and it's hard to explain, but if you hold an implant and having just the effect of gravity on it in a vertical position, it's going to ripple a little bit, even if it's overfilled and highly cohesive. So that rippling you can see, which is a major issue actually in breast reconstruction, but also an issue in breast augmentation.
And it can obstruct the view of a mammogram.
Right. Now, I'm not sure how true that one is because
that actually comes from the board.
It does? Okay.
That comes
I thought
from
they clarified
board
this
data.
recently, but maybe not. All right. Well, I'll take that. That's fine. In some cases, it may help with detection, especially with the exams. But I think in general, staying further away is, I mean, submuscular is going to be better.
Clearer mammograms is submuscular.
It will be. Yeah, you're right. Okay.
Yep.
Submuscular, which is the most common way we do it, you get more coverage, at least of the upper half of the implant. That's the actual muscle itself. You do get a reduced risk of capsular contracture. We've talked about this many times before. Underneath the gland has bacteria in it. Capsular contracture, which is scar tissue that forms around the implant, comes from contamination.
That's one theory.
Yeah, biofilm.
Yeah, we don't know entirely, but that is the biofilm
Why
theory.
you got to bring that up?
Well, because I
was trying to sweep right past that.
You know why I bring that up? Because we don't put out misinformation. We tell the truth.
I hate you. I was trying to Zamboni over that, just right between the halves or the quarters.
And if your doctor does tell you that there's only one cause of capsular contracture and he knows exactly what it is, like send him our way because we'd love to know.
Right.
As would all of medicine.
So we could talk about that at length, but it definitely has a reduced risk of capsular contracture. So you have less scar tissue around the implant. And according to Amy, which maybe I'll agree with this, clearer mammograms. At the very least.
Again, that comes from the board data.
No, I'm with you. I'm sure it is. Disadvantages, potentially more animation deformity, and that's what we call window shading deformity. More postoperative pain for sure. The benefit of going above the muscle is you don't violate that muscle. That muscle hurts after surgery. It starts to spasm and aches.
Well, you've changed its plane.
Yeah, it hurts. And not just pain medications, but muscle relaxants are really helpful after breast augmentation. And a longer recovery for sure. So
you'll have more restrictions on things like lifting because you're not going to move that muscle.
So if you go to a cosmetic surgeon and they do breast augmentations in the office, most likely what they do is do it with you awake, inject local anesthesia into the subglandular plane, make a small incision and put the implant in. And you could tolerate that awake for sure. But going underneath the muscle, which is a better position for the implant, it would be hard to do with you totally awake. You would have to have at least sedation through an IV and preferably general anesthesia. So that's why you'll see these subglandular augmentations are usually done in inferior circumstances. I'm not saying it's wrong, but it doesn't seem right to me. How would you say that?
I like you just said it.
Okay.
I wouldn't change a thing. I would not change a thing. Yeah. But there are other.
Not trying to be controversial, but
no. But there are times when we will go above the muscle. Well, I'm saying above the muscle because that's the common term that people understand. And those cases are typically when someone is a competitive bodybuilder.
Right.
Where their appearance is very dependent on their showing their body. And if you have an animation deformity where when you flex your muscles, your implant does a weird thing, like pops up a little, does a weird thing because you're flexing your muscles. Like that doesn't look great on stage.
But then we've had bikini competitors with the implants below the muscle and they do just fine. So it just depends.
But bikini doesn't have to flex their chest on stage.
I gotcha. I know this now. I've learned it over time.
Yeah.
But you're right. So it's that true bodybuilding person.
If part of your division is to train your chest aggressively, you're probably going to want your implant above the muscle.
Yeah, totally.
Yep. And even a lot of bikini competitors do because they want the most natural look because they get so lean.
I'm not sure it looks more natural because there's more implant show. It's hard to say. I think if you had any kind of laxity in your breast envelope, it would be more natural above the muscle. But then
you get skin wrinkling and rippling and other issues.
And then do you want more natural in some cases? Right. I mean, it depends on what you want out of the surgery. Exactly. Most people want more of a youthful kind of projected look.
Well, natural means different things to different people. Natural doesn't necessarily have anything to do with natural for your age.
Okay. This is like talking to my kids about God. I mean, it's like, oh, here we go. Everyone has their opinion.
God is a feeling.
No one knows the truth.
But they do. That's just it. And that's why it's important that your doctor understands what your idea of natural is. Because it might not be.
Your idea of natural may be 800 cc implants.
Yes.
I mean, I want the largest implants, but I don't want to double stack them. So I figure I'd go the more natural rack.
Yeah, natural. Yes. So there's definitely positives and negatives. I mean, you should definitely talk to your surgeon about what might be the best option for you, not so much what what your friend did. Find out what your lifestyle kind of dictates, and the size of the implant, is definitely part of that decision as well.
Right.
What is it, over 350 cc's is not really recommended above the muscle because of the risk of the added increased risk of capsular contracture. So if you're going for a really big implant and you also want to go above the muscle, again, there's pluses and minuses with everything. And there's not great statistical data on any of it.
No, and even if there was, it's really hard to understand what's going on. There's bench research going on in terms of capsular contracture and anaplastic large cell lymphoma, and we still don't totally understand what's going on. We do believe that it's a biofilm caused from contamination at the time of surgery or from the glands, the bacteria that's in the glands. Causes a subclinical infection or at least inflammation that then leads to scar tissue formation, and in worst case scenarios, anaplastic large cell lymphoma. That's probably the best way to put it. From there, I mean,
we're going to talk more about that.
Yeah.
That more on that is coming on future slides.
Oh God.
Yeah. So let's talk about, before we get too deep into the risks, let's talk about incision options.
Yeah, there's 3: armpit, around the areola, base of the breast. Armpit we don't do as much anymore. Some people do it. It tends to be older surgeons. I feel kind of strongly about this. I've said this many times before. Having an incision, even if it's in your axilla or within the hair-bearing armpit, is still visible with some types of clothing.
In a lot of types of clothing.
So what's the benefit then?
Yep.
I mean, you're more likely to show your armpit than you are your chest in normal work situations, depending on what job you do. So around the areola is fine. Higher incidence of contamination there because you're more near the ducts. With that said, that's a good way to do it, especially if you're doing a lift at the same time. But the scar is visible. When you're looking in the mirror, you'll see the scar around your areola. It heals well, but still visible. So we usually go at the base of the breast.
Mm-hmm. And really, I think there's a couple of key things to think about when you think about the placement. Should be based on the type of implant, obviously. The degree of enlargement, so the size you're going. If you want a really big implant, but you also want to go through your axilla and you want silicone, that's going to be really challenging.
Right, because you would have to make the incision bigger, right? And you have to do more dissection to get to the area where you want to put the implant. And then also it gets more complicated. It's something called a dual plane, or releasing the inferior or lower attachments of the chest muscle and allowing that implant to sit in there without riding high. It gets very difficult through the axilla or through the armpit. So you're kind of limited on size. Yeah. And then it's kind of true with the areola, because what if you have normal size areola? You're going to make the incision all the way around your areola just to be able to fit that implant in. The inframammary, or at the base of the breast, gives you the most options, the direct access to the muscle that you need to release in a dual plane situation, and better visualization than all the other ways.
Yeah, less trauma to the breast.
Yeah, a lot of times people will use the axillary approach, and they'll use a video camera, an endoscope, which is cool.
Cool for who?
I mean,
is it cool for the outcome? No,
but
exactly.
At least you're pulling a camera out.
Yeah,
it makes you feel very important,
right,
as the surgeon. But I think base of the breast is pretty standard.
Yeah,
SOP, as we say in the biz.
Yes, And your anatomy obviously is going to play a part in that. And also, I put this as the last one, the patient surgeon preference. If someone has a really strong preference one way or the other, we'll at least talk to them about why or not that's possible. Like sometimes it is, sometimes it isn't, based on other things.
I wouldn't be adverse to doing the a periareolar approach or armpit approach. That's not bad.
If it works for the implant size and the person, absolutely.
Sure, yeah.
So are we going to tell you why that may not be what you think it is? Absolutely. And why, the inframammary is kind of the gold standard for a reason in most cases. It really is the least traumatic approach as well, especially when we're talking primary breast augmentation. You're going to have surgery again on your breasts. Like, you go the least traumatic approach for the first one. But again, that's something that you need to talk to your surgeon about prior to surgery. So 3 options there. All right, let's take a quick break. We're going to come back and talk some more about the afters. The afters.
I'm going to talk to my bobblehead during the break if you're okay with that.
You guys go ahead. If this is a private conversation, Nils and I can leave.
Yeah. Can you guys leave? Please leave.
And we're back.
We are back.
Feels kind of crowded in here with 2 of you.
What do you mean?
Like there's 2 of you.
Oh yeah,
yeah.
Yes,
He's like I feel like I'm like so the minority anyway, and then we got 2 of you. So yeah, all right.
I'm going on a trip, and I might take a baby Bjorn and take my bobblehead with me. So
you don't even need. You could just put him in a pocket.
Oh, it's true. Just so you can experience what I'm going through.
Buzzsaw off his base so that he doesn't stick out so much.
So you're gonna cut the bobblehead in half?
No, just take the base off. Yeah. All right. So let's get into the nitty gritty of risks and complications because no surgery is without risks. No surgery is without risks. However,
way to burst everyone's bubble. Yeah.
There are specific risks to this procedure that definitely should be considered prior to surgery. And these are important things. I feel like education is really the best way to not only ease fears, but also to understand the progression of the life of this surgery. More so than other surgeries, this is leaving something behind. A lot of the surgeries we do, we're taking stuff away, like fat and skin. In this
things
surgery,
you didn't want.
Yeah. In this surgery, we're giving something you do want, but we're leaving it there. So, what's it going to be like?
You have to deal with it. Yeah, I know. Yeah. It's like dropping the puppy off at your friend's house. Like, I'm not going to come back and pick it up. Yep.
Yeah. So what are the risks? Dr. Martin brought these up in the first episode. Bleeding, infection, those are important risks to know. But also, I think one that is really important to know is the risk of or the need for additional surgery. And that might be immediate need for additional surgery.
Yeah, and those consents you sign, which we talked about in part 1, as mandated by the FDA through the manufacturer, talks a lot about the fact that breast augmentation is not a permanent surgery. And that's sometimes people are like, what? And I'm like, yeah, no, it's not permanent. In your mind, you can think, and they say an arbitrary number, 10 years, that comes from data, but you think in your mind,
what happens in 10 years?
Yeah, every decade, you may need a little touch up, a new implant. You may have scar tissue. The implant may fail.
Implants don't stop aging.
Right. Actually, the FDA recommends a screening MRI for silicone breast implants 5 years after your initial surgery and then every 2 years after that. Amy, why do I know that? Because I took my in-service exam.
And that'll actually be on the next slide.
And actually, I read it in the consent form. I already knew that beforehand, but it's really good. So again, board certification, in-service exam. Right? I'm a middle-aged dude, and I'm still kind of keeping all that knowledge in my head. Other things, change or loss in breast sensation. Such a really good thing to point out, Amy.
Yep.
So
yeah, we've had patients who are so concerned with any change or loss of sensation that they've decided that the risk of having a breast augmentation is just not worth it. Now, you can minimize these risks, as we talked about in the previous slide with the placement of the implant. Obviously, a placement that is doing the least damage possible to the breast and also away from the area where the breast gets its sensation from, which for the breast is feeding mostly from above, some from the side, but really what innervates that breast is coming from above. So if you are, needing to do a lot of dissection above to get an implant in from the armpit, that's obviously going to be maybe more, potentially could be more risk of damaging some of these things.
It's definitely more anterior. So if you stay below the muscle, because actually the innervation comes from above, which is where your clavicle is, but also from your chest, and then from the sides, and all those come around 3-dimensionally and innervate the nipple and areola. So theoretically speaking, if you take an inframammary approach and go underneath the muscle, it'd be pretty unlikely that you would affect those nerves. But when you release the muscle toward the chest bone, the sternum, is there a layperson term for that word?
Sternum.
Okay. You could get into where those nerves are because that's where they come out. So that's the key. And you cannot guarantee, even if you don't touch those nerves, that the sensation won't change. Just by the mass effect of that implant, especially even under the muscle, would cause stretching of the soft tissue, irritation of the nerves, and you would have less sensation. What we see more commonly is hypersensation after surgery,
especially for a couple months,
which is disconcerting, and that almost always resolves, but it bothers people too. So sensation is a real problem, or a change in sensation. Complete loss of sensation, at least in our hands, is pretty unusual. I've never seen that personally, but
very rare. Yeah. Big ones are going to be a mispositioning of the implant.
Yep.
Again, the type of placement you choose initially is going to mitigate that the most.
The axillary approach or through the armpit is going to have a higher malposition rate with that approach. And the positioning, the malposition would be up. The implant would float up. It'd be too high. We've had one case where it went up and over, which was very odd. And we didn't even dissect in that area. And she had lost a lot of weight. I just don't think her soft tissue was really supportive. So, but yeah, you can have a malpositioned implant that has to be addressed. I mean, that has to go for another surgery.
Yep. And that's as we talk about in our episode where we talk about complications with breast augmentation, the solution for all of these is additional surgery. So there's a solution for these things. It just involves additional surgery. Implants that have leaked or ruptured, additional surgery. Capsular contracture is different than just having a capsule. Every implant of any type is going to develop some type of capsular protective coating around it from the body. Capsular contracture is a specific condition where that capsule starts to, as the name would imply, contract or become painful or build up. It's not just the normal capsule.
And you can see it. It's a clinical diagnosis. And feel it. So, there's different levels of capsular contracture. I think there's 4.
The Baker grades.
Yeah. And then that 4th is really severe, and you would know it right away when you see it. But even level 1, you can see a little bit of a change, but it's barely visible. And then definitely palpable in all 4, and just gets worse, worse, and worse. And we've seen some terrible capsular contractures.
Yeah. Fluid accumulation, which we kind of will talk a little bit more about in a second. Skin wrinkling, rippling, implant show. Those are all risks, well-known risks. Some people, that may really bother them. Other people, they just accept it. And there are times when we tell people up front who are very thin or have very thin tissue, you're going to have some implant show, or you can be able to feel the implant in certain places. That's just normal.
Right. It's maybe not as much the show of the implant, depending on the size of the implant you use, but the feeling of the implant is what freaks them out.
Yeah, like you're going to be able to feel it.
Yeah. I mean,
feels like an implant.
Why can't I feel this? Because like you had no tissue there to begin with.
Especially in the lower
There's nothing
pole.
covering it but skin,
Yeah,
especially in the lower part. Yeah.
Yep. Pain, which may persist. Like there are definitely cases where these are, again, risks of any surgery. You cut through tissue, nerves may not fire the same way for a really long time or even ever. Like you may always have some weird sensations in certain places. Let's talk about the big one, Dr. Martin. This is the one true, like, let's say, scary complication or risk that really should be talked about and thought about because it's real. There is a specific type of lymphoma. It's not breast cancer. It's a cancer of the lymphatic system called breast implant associated anaplastic large cell lymphoma, BIA-ALCL, or there is one also that is now being brought more to the forefront that's extremely rare, is breast implant associated squamous cell carcinoma. That is extremely rare, but it's also extremely deadly, which is scary. These are rare types of cancers that develop in the capsule around the implant, like on the capsule itself and in the fluid around the implant.
At least with BIA-ALCL, it's T-cell related, so it's part of your immune inflammatory response.
Yep. And is even if you do develop it, the treatment for it is highly successful. Removal of the implant.
Yeah, the BIA-SCC is a little bit different, but that's extremely rare. Both of these are extremely, extremely rare. Very, very rare.
Yep. But you should be aware of them.
You should be aware and understand the symptoms of how those present, which is swelling unilateral on one side, some discomfort, maybe even some mass that you can feel. And these are things, if you have anything along that line and you've had previous augmentation, you have to get examined. The first line examination per memory is an ultrasound, but
which looks for fluid.
Yeah. If you have fluid, they'll aspirate the fluid, and that free fluid is going to be very definitive. I've done that before where you send the fluid off. I've also done it where you've sent the capsule off because you've done it during surgery, you saw fluid, you're a little bit concerned. And they do these special evaluation. I think it's called flow cytometry, FLOW cytometry.
You spell flow. I think most people know how to spell flow. Spell cytometry.
I didn't want to spell cytometry. Isn't that funny?
Yeah.
I was
What
like,
is it? Ferris Bueller? Voodoo.
Voodoo, V-O-O.
Voodoo economics.
Yeah, D-O-O economics. So flow cytometry, and it will tell you if there's that clonal amplification of the certain type of T cell line. So
Yeah. And that's also why it's important to do your regular breast monitoring, which we'll talk about more in our recovery slide. That's not just like there's reason for this. And I always tell women when I'm talking to them about, kind of care for their implants after, like they'll ask me, when can they stop doing like their implant massage? I'm like, well, you really should never stop doing your breast examination. So this movement of your implant and the way the implant feels and moves within your breast tissue, it's important to know how that feels always, because if something changes, you should be the one to notice that. Relying on only external things to like tell you that something's going on with your implants is not the best line of defense. You should know how your implants are feeling. So you should know when things are feeling different. And when they do, don't ignore that. Like go be seen by somebody. And hopefully it's nothing. Capsular contracture can kind of start to do weird things and it might be fine. You don't need anything, but don't ignore these symptoms. The big one that is talked a lot about, not so much, I feel like it was like 5 or 6 years ago when there were a lot of really vocal like YouTubers and influencers who were struggling with their implants, and a term came to be part of our vernacular, this breast implant illness, or BII. This is real. It's a systemic symptoms which can include fatigue, brain fog, joint or muscle pain. A rash is pretty common.
I feel like I have 3 out of the 4.
Right? Maybe we should get your implants out.
Yeah.
And these are things that, as Dr. Martin mentioned, they're affecting you on a more autoimmune level. So anytime you have something in your body, and this is not specific to breast implants, this is any implant that's in your body can cause some of this insidious inflammation, right? Your body doesn't really know what to do with this foreign invader. That's why I say a capsule, it will form around all implants as your body kind of walls it off. Like, okay, it's doing that thing.
Right. That's evolutionary.
Mm-hmm.
Like your body, for any foreign body, is going to wall it off, right?
Like,
because
put
that's
this
how you
over there.
lived before we had us.
Yeah.
In the old days. And it's so funny. We all look at time related to civilization, but humans have been around for millions of years. And in our current form, for a couple million years. And over that time, the people that lived for the majority of that time were able to wall off infections, foreign bodies, and appalling injuries. And that's what it's doing for your implants.
Yeah.
Some people would just do that better than others, and it may not even be a problem with your body. It just maybe your body is hyper aware and hyperactive.
Mm-hmm. Or you're just so stressed out that you're kind of making your body reach its limit with dealing with something.
Yeah, and now you can understand. So that's why the biofilm theory of implants it makes sense. I mean, if you think about it, so not only are you putting a foreign body in there, which is going to wall off, right, because it doesn't recognize it as human or yours. Then you're going to put bacteria on that, which it recognizes as an insult.
Which could be some rare hospital strain of virus
or anything.
bacteria.
Yeah. So your body is going to be more inclined, react more heavily to this foreign body and create an even stronger scar tissue around it. That's why I usually see capsular contracture within the first couple of years. Like every now and then you get it, it presents like 10 or 15 years afterwards. But usually if people have definitive capsular contracture, you start to really see it within a short amount of time, a couple of years after surgery.
Yeah, and that's
the initial presentation.
The same thing with I think they said, at least initially when data started coming out about BIA ALCL, it was looking like it was between 5 and 7 years that most people were noticing it.
Yeah.
And is that just because it finally progressed to the point where people had active symptoms? Perhaps. BII, I have heard across the board people who like immediately wake up from surgery and are swollen forever. Until the day they get their implants out, they feel swollen or they have a rash or whatever, like they blame it on it right away, or people who like 5 to 10 years later start getting these symptoms, start having brain fog, can't lose weight, some other type of like systemic symptom that they start having that they then relate back to their implants. We've had some patients whose rheumatologist did recommend that they have their implants removed, and it did make a difference for them.
Yeah.
And I always tell people that's the great thing about breast augmentation. It's not a permanent surgery. Like you can change the size, you can take them out, you can put them back in. Like it's like, look at it as a fun thing.
It's the hokey pokey.
Like, yeah, it's additional surgery, but none of these things, like they all have a time limit. So
right.
Even if something really severe happens, enjoy your implants while you've got them, or don't take them out. Like there's options.
Yeah, I mean, just
to treat all of these things.
BII is still confusing, but it is real. At least some patients present with these types of symptoms. And
autoimmune conditions are real.
Yeah, you can understand. And the rheumatology literature is pretty ambivalent on silicone breast implants. It's not like rheumatologists are saying don't do breast augmentation with a silicone breast implant.
But if you have an autoimmune condition.
But if you have an autoimmune condition that's worsening, or you have all these kind of problems, the rheumatologist, of course, is going to say, try taking your implant out. It doesn't hurt. It can only help. and maybe that will solve the problem. That's few and far between, though. Yep. I mean, the number of in my career, the number of patients that come back with like BIA symptoms, I can't remember. I'm sure there's been one or two, but I cannot.
No.
So I don't think this is a common threat, but there are people suffering out there, and they should understand, and you should understand, if you have those problems, the answer is taking the implant out and the capsule, a total capsulectomy.
Yep. And there are definitely doctors out there. I actually listened to an interesting podcast recently with a doctor who, now does methylation testing on patients prior to surgery to see like if you have certain MTHFR mutations that may make you more likely to develop these, but there is no real science on this just yet. So there's no test for BII, definitive test. There's no test to know if you might have it, if you might be prone to getting it. However, if you have autoimmune conditions prior to surgery, anything you do that causes your immune system to have to be activated is obviously going to raise your risk of anything.
Mm-hmm.
So, and that's of anything. And it's not just breast implants. The same thing happens with hip implants, joint replacements, any type of implant you're putting in your body.
Stimulators, some sort of deep brain stimulator.
Pacemakers. You can have these types of symptoms with any implant. So I don't want...
Spinal stimulators.
Yeah. Breast implants kind of get a bad rap, but
right,
only because it's elective.
Pretty much everything that you implant in your body, most of them have some component of silicone and other things and metal.
Well, and activation of your immune system.
So your body is going to wall it off just like it does in your breast.
Anything. Yeah. All right. Well, let's talk about some other important considerations that are specific to breast implants. We've kind of talked about these somewhat, but the first one, breast implants are not a lifetime device. Future surgery, I said may. Let's be real. Will be required to replace or remove your implants. You want to lift. Implants don't stop your breast from aging. So if you needed a lift, you need a lift. You're going to need a lift if you don't get implants. You're going to need a lift if you do get implants. You might want to change the size. You might get pregnant, gain weight, lose weight. Menopause makes your breasts grow. You may need a reduction when you exchange your implants. Your breasts will change in appearance over time. Implants are not going to stop they're not going to stop that. So thinking to yourself like, oh, I don't want to get implants because then I'll need more surgery. Well, let's be real. If you want your breasts to stay high, you're going to need more surgery anyway, with or without the implant. So get your implants. Implants require regular monitoring and examination. MRI or high definition ultrasound, which is a new way of looking at implants, which is really cool, is recommended to ensure your implants are intact and stable. And Dr. Barney was at first 5 years and then every 2 years, correct?
That's right.
Yep. So MRI will likely not be covered by your insurance, and neither will some of these really cool high definition ultrasounds, which
are expensive.
They are expensive and they're self-pay. So knowing those things up front and knowing that and being a responsible implant owner, these are key to the health and life of you and your implants.
Right. And the reason why we don't get MRIs instead of mammograms, MRIs are highly sensitive. So it picks up a lot of different things. So you have to realize too that if you get an MRI, they may find something that they say, well, this is concerning for cancer. Then you would have to get a biopsy. That costs money and that has recovery. And, it may not be anything. So you're running the risk of having, excessive testing and sampling and biopsies and stuff like that. Most of the times the biopsies are done percutaneously with a small little coring needle.
Yeah. Even the data, though, on breast biopsies, like you're more likely to develop abnormal cells in the area of previous biopsy. No, statistically. So
no, I mean you got to sample the tissue.
That's what I mean. But
that's like baseline medicine. So
no, that's what I'm saying. Like all medical procedures, like everything leads to something else. So don't ignore any symptoms that you have with your implants.
Right.
Like get it checked out.
But if you're getting an MRI, 5 years after that surgery, and then every 2 years, and you're following exactly what the FDA says, I mean there's going to be a higher likelihood that you're going to get unnecessary biopsies. Because in an American healthcare system, if they see anything that's concerning from a CYA standpoint, they're going to biopsy it. So you have to realize if you follow and it's a recommendation, it's not a requirement.
No, but don't not do it because you don't want to.
I understand, but like you're accepting. Okay.
Yeah. Get your routine medical exams.
I mean, we want to like educate people until I'm not supposed to educate them, right?
No, but that's what I'm saying. Like you should get them. And the risk of additional biopsy, there's risks, but like that doesn't mean you shouldn't get your MRI.
But the point is, if you're someone that doesn't like to go in for biopsies and be seen and get exams and sit in an MRI,
no one likes to get biopsies.
Well, then don't get a breast augmentation.
There you go.
It's an elective surgery. Yeah. That's what I'm saying.
You will still need probably breast biopsies without implants.
That's for sure too.
Yeah. So
I read somewhere, I think it's like 20% of all mammograms.
It's not easy being a woman. You guys, all three of you, especially you, especially the little guy there. He's got no problems. His prostate's probably totally fine too.
That guy hasn't aged one
He's
bit.
got nothing. He's got no
Yeah.
problems. He seriously has no grays. Like,
I know.
he's ageless.
He's looking good.
Again, if you're not watching this, you have no idea what we're talking about.
Doesn't
We're talking
matter.
to Dr. Martin's bobblehead.
It's our little Easter egg for you too.
Yes. All right. Let's talk about recovery and results. So I broke this down into 5 sections. The initial is basically meaning like when you wake up from surgery, what should you expect? Swelling, tenderness, discomfort in the breast, muscles, and at the incision site. You might have bruising. Some patients really bruise from breast augmentation. That is going to have a lot to do with the size of the implant and also the technique your surgeon uses. Temporary changes in nipple sensation and projection. You should expect that that is normal. Don't
For sure.
freak out that when you wake up from surgery, like your nipple sensation has changed. It will be. Breast may appear uneven, misshapen, or even sitting very high on the chest. And I
Yeah.
mean like so high that you feel like you can just set your chin right down on them.
And they're not setting that high. The muscle, in most cases, you go underneath the muscle. The muscle
Super swollen.
gets more edema than the soft tissue, and that's because muscle has more circulation there. Circulation leads to flow in lymphatics, and then that's where the edema comes from. So the muscle in the upper half of the breast really swells because it's traumatized. And that's what you're really seeing is that muscle swelling. A little bit of the implant, but more the muscle swelling.
Yeah. I mean, you can expect, I'd say, most patients that your implants or your breasts, not your implants won't change size. Your breasts will probably appear about 30% larger right after surgery than they will 3 months
Sometimes
after
people are
surgery.
super pumped about that. When the swelling goes down, they're like,
Oh, like maybe this was okay. Yeah. Like, oh, I want that back.
I want that back.
Or just like how high they are, like that. Yeah, they're first freaked out, but it's fine. So those are all normal things. So first week, you definitely have some limited activity, sleeping on your back in an incline, as we discussed in our first episode. Probably be taking at least over-the-counter pain medication and some muscle relaxants. Dr. Martin talked about the need for muscle relaxants after surgery, and wearing a soft-sided stretchy bra anytime you're not showering. So that first week is pretty chill.
Yeah.
You're walking around T-Rex in it. You've moved everything in your house to be at waist level, so you're helpful to yourself.
Definitely in pain.
Yeah.
Definitely in pain.
Discomfort. Yeah. Pain is subjective, but you're definitely going to be taking something. Yeah. 2 to 3 weeks. So weeks 2 and 3, most likely return to work. Some people probably even return to week one.
If you're off the opioids, if you're off the pain medication.
Yeah. Doing some work, especially from home, especially if your work is non-active. Return to work, return to driving. You want to make sure that you are definitely off pain medication and even off muscle relaxants before you start driving. You'll be feeling a lot better. Might probably start doing some gentle implant massage and some return to easy exercise in those first couple of weeks with restrictions for sure.
And walking is like super important from any surgery standpoint because it increases your circulation, decreases swelling. It's medicinal. It decreases inflammation. It helps your blood pressure.
Helps recover from anesthesia.
And it gets you away from your family members that are annoying the living hell out of you. So
Maybe one of them would walk with you.
True.
But don't walk your dog.
Don't walk your dog. Yeah.
See, Nils is listening. Good job,
Nils
Nils.
knows. Unless your dog weighs like 3 pounds, you're not walking your dog.
This is the dog walking is what kills us all the time. And it's always the same story. He's a good dog.
You just saw a squirrel.
Just saw a squirrel.
Couldn't help it. Yeah. Weeks 4 to 6, you're going to be gradually increasing your activity level, getting back to more aggressive exercise, getting your heart rate up. You're going to continue your implant mobilization forever. You're also going to continue to be gentle with your breasts. Like, I love when people come in, they're like, well, I'm 4 weeks out. Like, I can't believe I'm still having any discomfort or I'm still swollen. Like, yeah, you are 4 weeks out. Like, you are in the acute recovery phase. I mean, to me, like, I really feel like the first 16 weeks, like you're in that kind of acute recovery phase. Like, recovery takes time, and it takes time.
Tell me what
don't
activity
see.
does not involve your chest in some way, besides like squats. And even that, like if you're squatting and you have something over your head, you're kind of balancing it with your chest. And it's impossible to do most activities that don't involve movement of your chest muscle. And that hurts. I mean, it's going to hurt even after surgery.
And could be damaging to the effects of the surgery.
Yeah.
So you want to listen to your doctor's post-op instructions.
Which is why the benefit of doing alligator arms or T-Rex arms is keeping your elbows in. So you're not really activating that pectoralis major muscle, which has an attachment where, Amy?
On the sternum.
And?
The acromion process of the shoulder.
And the humerus, right?
Mm-hmm.
Yeah.
Yeah.
So.
Yeah. So beyond that.
Is there any anatomy question I've asked you that you didn't know the answer to?
I'm sure. Oh, Cooper's ligaments. I mean,
Yeah.
like 1,000 times.
That's because you have a learning
I have
disability.
a mental block for Cooper's ligaments. Yeah. Never again. Yeah. Once it's in for life.
That's going to be on your epitaph.
Yeah.
It's like she was a good person
Cooper's
and she
ligaments.
finally, by middle age, remembered Cooper's ligaments.
Cooper's ligaments, yes. So beyond that, so 6 weeks is kind of that, when you have your most intense restrictions. So beyond 6 weeks, I say 7 weeks and beyond, you can return to most normal activity. Doesn't mean that you will right away. I mean, there are definitely things that I don't recommend people get back to, like pull-ups. you might not do pull-ups for 6 months after surgery. You might not really ever feel totally normal doing some exercises at all, that don't make your implants feel a little weird. Side sleeping, you can try. If it feels okay. It might not. It might not feel okay till you're like 10 or 12 weeks out, and that's fine. That's normal. You're going to continue to perform your breast implant exam, mobilization, call it massage, call it whatever. You're going to continue to make sure that your implant feels normal. You're going to schedule your routine and recommended implant monitoring, Dr. Martin. And you know what else?
You got to love your implants.
You're going to love your implants.
Yeah, I love it, man. It's awesome.
Yes.
Let's go.
Like I said, it's like instant gratification.
Yes.
Like, love your implants. Like,
I feel like we should give everyone their before and afters just so they can sit there and revel in the fact that their breasts look so much better.
Well, not better. I mean, like, your breasts are your breasts, but like they look bigger. Like,
better. They're better. Yeah, enjoy it. Have fun.
Yes.
This is so much fun. It's a fun surgery. It solves a problem and it's definitive.
Yes.
And it's going to last for a long time. So.
Yeah. And eventually you're going to need more surgery. So love them.
Yeah.
Like, love your implants. All right. I think, Dr. Brown, we covered everything you need to know about breast augmentation.
We totally did. Yeah, we didn't really get too in the weeds about the surgery itself, but I'm not sure how much people care about that.
Our other episodes cover that in a lot of detail.
Yeah.
So like this definitely, I was trying to give us like the good overview of everything.
Yeah, I like it.
Yes. Like we didn't, show the surgery. There's no before and after pictures that we're
yeah,
showing.
this wasn't like a subreddit. You get in there and you're like, oh my God, who are these people?
No,
like,
this
do they
is
just
stuff you
sit
should
around, into the minutia? If you get stuck in a subreddit on any topic, you're never getting out.
So you don't read comments on YouTube videos, but you're on Reddit?
Oh, I'm all over Reddit.
Wow. See, I love reading comments on YouTube videos.
Yeah. I mean, the comments on YouTube videos usually are kind of snarky and witty and funny and whatever, or good. I mean, the ones on ours are inspirational, which I like. But
no, I mean like when you are watching a YouTube video that you were interested in. Like on this guy listens to like true crime stuff. Like, yeah, I want to see what other people are talking about.
Never. But with Reddit, most of these people are nerdzillas, and I relate to that. So then they get into the weeds of whatever topic it is, and it's like always things I'm interested in. One of them is like United Airlines, which is like I don't know why, and I'm on these Reddit threads. It's so weird, and they're like half of them are showing like the new United Club here or this United plane, like the new detail, the decals on the plane. And I find it fascinating, even though it has no value to my life.
Vanessa was super
even with
Reddit.
traveling, because I'm not even.
You don't even fly United.
No, not even that much.
Yeah, I don't do Reddit, but yeah.
No, it is crazy when you get into Reddit. I mean, seriously, when you get down into like
I feel like Twitter is the same way.
Twitter is full of people that are insane.
Like Catherine was like deep into a Twitter thread on a specific topic that we all find interesting, and I'm like,
Twitter is basically the loudest
she's
voice.
like, I read all 300 comments.
Yeah, Reddit's more like Wikipedia, but expanded with comments, and it's like informational in most cases. I'm sure there's Reddits that aren't that way, but I find it just more informational.
Well, anytime there's people talking about things online, there's going to be weirdness.
Yeah.
So
I mean, whatever. What am I saying? Reddit's probably just as crazy as Twitter.
I'm sure it is.
Highly specialized. Like if you like movie stuff or video games.
Yeah, whatever your thing
it's
is.
It's like the group of nerds in the corner.
It's total nerds. It's total nerds.
It's what were those when you were in club? It's after school club.
Yeah, it is.
It's after school club.
Mm-hmm.
Yeah. Well, thank you everyone who made it to the end of this podcast. This was part 2. So if you did not listen to part 1, I do highly recommend going back and listening to part 1. A lot of good information in that. And again, all of the previous episodes about breast augmentation, the myths, the more details about how to select implants, those are all going to be found in the links below and also in our amazing catalog of other podcasts. So do appreciate everyone for listening. It does make a big difference to me when you like our podcast and leave us a comment. I love reading comments and responding to them. So please
and follow us too. It's very important.
Follow us, yeah. Well, the Uncle
or
Cracker
subscribe.
song.
Excuse me, subscribe.
Yeah, it's subscribe and hit that bell for notifications. Now I feel like a real influencer. All right, before I get too far down the weeds of our weird little Reddit group here, where only we get the joke.
Yeah. Ow, that hurts.
Got to do all my things, right? Yeah, all my trademarks. Bobblehead, hit him in the shoulder. Let's chink some cups while we're at it. We're doing all the things. This is like there are benefits of watching to the end of our podcast. You get to watch the antics. All right, everyone. I will let you go now. So please leave us a comment, a rating, review. Follow us. Send us to your friends. You can also leave us a voicemail at 303-630-9038. I do appreciate it.
And one last thing, breast augmentation is awesome.
Yes, love your implants.
There's a lot of things about breast augmentation. It's about empowerment, education, knowing the risk, but we love breast augmentation, and there's nothing that replaces it. Fat transfer is not going to equal
we have an episode about that too.
Yeah,
breast augmentation without implants.
Hey, if God or nature gave you smaller breasts and you want a little bit bigger with
maybe
some better
big
contour,
breasts, you want them to be bigger.
Yeah, or if you have big breasts, you want them bigger. You're post-pregnancy.
We got you.
You're 50 and you're like, I've always wanted a different breast size, different contour.
And you don't need a lift.
Breast augmentation is awesome. And if you go to a board certified plastic surgeon, someone knows what they're doing, you're gonna get a great outcome. So don't be afraid. You're totally educated now. It's gonna be awesome. We're super pumped for you. Write us a comment and tell us how it went. All right.
We're out.
Bubblehead says goodbye. Amy, bye.